Hello everyone. Today topics is typhoid fever. It is an infection feverish disease caused by the bacterium Salmonella typhi, Salmonella enterica, Cerovar typhi, and less commonly by Salmonella paratyphi. It is acute generalized infection of the reticular endothelial system, intestinal lymphoid tissue, and the gallbladder. The infection always comes from another human, either an ill person or healthy carrier of the bacterium. The bacterium is passed on with water and foods and can withstand both drying and refrigeration. If we look the history, we can see the clinical and pathological features of typhoid fever were first described in the 19th century by Lewis and then by Jenner. The term enteric fever was proposed by Wilson in 1869. Around 430 and 426 BC, it is believed that typhoid fever killed one, uh, one third of the population in Athens. This was long disputed, but after a DNA discovery in 2006, it was determined that it was the typhoid fever bacterium. Between 2004 and 2005, an outbreak in Dominican Republic occurred with 42,000 cases and 214 deaths. About typhoid Marie, the best known carrier was typhoid Mary. Mary Mellon was a cook in Oyster Bay, New York in 1906, who is known to have infected 53 people, 5 of whom died. Later returned with false name but detained and quarantined after another typhoid outbreak. She died of pneumonia after 26 years in quarantine. So these diseases caused by the bacterium Salmonella typhi, ingestion of contaminated food or water, contact with an acute case of typhoid fever, water is contaminated where sewerage system and poor sanitation, contact with a chronic asymptomatic carrier, eating food or drinking beverage that handled by a person carrying the bacteria, and Salmonella enteritidis and Salmonella typhimurium are also Salmonella bacteria caused food poisoning and diarrhea. The species that cause enteric fever are Salmonella enterica, serotype typhi, and Salmonella enterica serotype paratyphi, which include A, B, or C. Salmonella enterica, it is a member of genus Salmonella. It's a rod-shaped, flagellated, aerobic gram-negative bacterium. Large number of fimbrial and non-fimbrial adhesins are present, mediate biofilm formation and contact to host cells. Secreted proteins involved in host cells invasion and intracellular proliferation. Infects cattle, poultry, domestic cats, hamsters, humans, and other. Refrigeration and freezing slow or halt their growth. Pasteurizing food irradiation kills salmonella for commercially produced foodstuffs contain raw eggs such as ice cream. Food prepared in the home from raw eggs can spread salmonella if not properly cooked before consumption. You will see in high right corner by microscopy how this bacteria looks like. About epidemiology, enteric fever is a global health problem affected an estimated between 12 and 33 million people per year. The disease is endemic in many developing countries, including Indian subcontinent, Asia, Africa, and Central and South America. The organisms are spread by ingestion of fecally contaminated food or water. How this disease spread? Direct person-to-person spread is rare, and laboratory transmission has been reported. Outbreaks in developing countries may result in high morbidity and mortality. In developing countries, infection is usually associated with international travel. Also, foodborne outbreaks do occur. Where in the world we can find these cases? Typhoid fever is very common around the world except in industrialized nations such as the United States, Canada, and Japan. The global annual burden was estimated at approximately 12 million cases for 2010. Most of these were effectively treated with antibiotics. Also, the case fatality rate remains at about 1%, such as about 130,000 typhoid deaths occur annually. The incidence of typhoid and paratyphoid varies geographically, geographically, with South Central and Southeast Asia having the highest incidence, typically exceeding 100 cases per 100,000 person years for typhoid, and with lower variable rates for paratyphoid. In one multicenter study, the annual incidence of typhoid per 100,000 children aged between 5 and 15 years was 180 in North Jakarta, Indonesia, um, 413 in Karachi, Pakistan, and um, 494 in Calcutta, India. In the same setting, the annual incidence of paratyphoid was considerably lower, with the highest annual incidence reported from Pakistan of 72 per 100,000 children aged between 2 and 16 years. You can see in this slide average annual rate of eradication across 8 case countries with subnational estimates. This figure shows the percentage of the average annual related reduction in typhoid in Bangladesh, Chile, India, Nigeria, Pakistan, and Vietnam. The color gradients range from 22.43 shown in the dark green, indicating reduction in typhoid, to 33.31 shown in dark red, indicated an increase in typhoid incidence. Um, how is typhoid fever contracted? Typhoid fever is contracted by the ingestion of the bacteria in contaminated food or water. The bacteria itself only lives in humans and is carried through the bloodstream and intestinal tract. Both ill people and carriers of the disease spread the typhoid bacteria through their feces. Typhoid can be passed through animals, only through humans. Flies, however, are known to help transmit the disease because when the land of human excrement is remains on the appendages and can be transmitted when the land of something else. Affected organs in typhoid fever. It is liver, gallbladder, stomach, small intestine, large intestine. If we look pathogenesis, inoculum size and decreases gastric acidity are important determinants of disease severity. The ability of the organism to survive within macrophages is essential to disease pathogenesis and spread. Organisms multiply in Pierce patches, then enter the bloodstream and re-invade in the small bowel, causing bleeding and peritonitis. The B antigen of Salmonella typhi prevents antibody-mediated opsonization, increases resistance to peroxide, and confers resistance to complement-mediated lysis. You can see this in this slide, pathogenesis. So, Salmonella typhi bacteria is entering to cells and catch this bacteria macrophages, and then by mesenteric lymph node it goes to blood, and from blood goes to spleen and liver, and then may go to Pierce patch uncle. Salmonella bacteria invade small intestine and enter the bloodstream. How we say carried by the white blood cells in the liver, spleen, and bone marrow. Multiply and re-enter the bloodstream. Bacteria invade the gallbladder, biliary system, and the lymphatic tissue of the bowel and multiply in high numbers. Then pass into the intestinal tract and can be identified for diagnosis in culture from the stool tested in the laboratory. Uh, we have two type in classification typhoid fever. It is typical type and atypical type, which means raised and subclinical forms occurring with a predominant lesion of individual organs. Uh, Pneumotype, thyroid, nephrotyphus, colotype, and other. In form of severity is lightweight, moderate, and heavy. By the nature of the course is smooth, non-smooth. Clinical features, the incubation period range from 5 to 21 days depending on the inoculum size, age, gastric acidity, and host immune status. Abdominal symptoms including diarrhea, constipation, or abdominal pain may initially develop, then resolve. This is followed by non-specific symptoms, including chills, uh, diaphoresis, headache, anorexia, cough, weakness, sore throat, muscle pains, dizziness, delirium, or psychosis prior to the onset of fever. On examination, patients are acutely um, ill with fever, raw spots, abdominal tenderness, and hepatosplenomegaly. Cervical lymphadenopathy, respiratory um, crepitaceous, um, cholecystitis, pancreatitis, or coma may also occur. Complications occur in the third or 4 weeks of illness and include intestinal perforation of hemorrhagic endocarditis, pericarditis, hepatic or splenic uh, abscesses, and orchitis. You can see in the slides a coating, typical coating in typhoid fever. Um, it will be a dark brown color and maybe teeth marks on the tongue. Uh, in human body will appear raw spots, especially in the chest and abdomen. It's a raw spot. Mortality rates are less 1% in developed countries, but maybe is high as between 10-30 in developing countries as a result of delayed treatment of media strains. Long-term carriage presence of Salmonella in stool or urine for more 1 year occur in between 1-4% of patients with Salmonella typhi. It is associated with biliary abnormalities, concurrent infection with other bacteria, and increased risk of developing cholangiocarcinoma. How we put diagnosis? Culture definitive diagnosis requires isolation of the organism from cultures of blood. It's between 40 and 80% positive stool, 30-40 positive percent, or bone marrow. It will be 50, 90% positive. Other diagnostic samples include urine, raw spots, or duodenal contents. And combination of specimens increase the likelihood of diagnosis. Cultures should be tested for sensitivity to nalixidic acid. A resistant organism have reduced susceptibility to chemicals. Serology test like the Vidal test detect antibodies to Salmonella typhi. They are of limited clinical utility in endemic areas because they do not distinguish recent from past infection. Never newer ELISA and dipstick tests are better, but then their sensitivity and specificity are not adequate for routine diagnostic use. So, Whittle test, a test involving agglutination of typhoid bacilli when they are mixed with serum containing typhoid antibodies from an individual having typhoid fever, used to detect the presence of Salmonella typhi and Salmonella paratyphi. How do you read Whittle test result for typhoid fever? The highest dilution of the patient serum is which agglutination occurs is not. If the dilution is 1 in 160, then the titer is 169. Agglutination in dilution up to 1 to 60 is seen in normal individuals. Agglutination in dilution 1 to 160 is suggestive of Salmonella infection. Agglutination in dilution of and more than 1 to 3020 is confirmatory of enteric fever. So when we give and use differential diagnosis, we put other diseases like paratyphoid fever, similar to typhoid fever but usually less severe. Parenteric fever, a typhoid-like fever but not caused by Salmonella. For example, brucellosis, tuberculosis, Q fever, and viral hepatitis, and other. How we will do management? The emergence and spread of media strains resistant to ampicillin, cotrimoxazole, and chloramphenicol, and increasing resistance to chloramphenicol have made treatment challenging. Antibiotic selection depends on local resistance patterns, patient age, whether oral medication are feasible, and then clinical setting. Uh, Chloramphenicals are the first line treatment for uncomplicated enteric fever, apart from in areas with high rates of resistance. Regimes include regimes include ciprofloxacin 50 100 milligram or ofloxacin 400 milligram for 7-10 days. There are bactericidal bactericidal concentrate and the bile and result in faster resolution of fever. Ceftriaxone 2-3 gram daily for 14 days indicated in severe. Alternative agents include cefixime 20 mg kilogram day in 2 divided doses for 14 days. Azithromycin 1 gram stayed followed by 500 milligram daily for 5-7 days or 1 gram daily for 5 days. And chloramphenicol 2-3 gram in 4 divided doses for 14 days. Corticosteroids. Early studies in the 1980s suggested that dexamethasone was associated with reduced mortality in critically ill patients treated with chloramphenicol. It is not certain whether this finding would be confirmed in the post-chloramphenicol era. Surgery is indicated in patients with ileal perforation. Relapse. This may occur 2-3 weeks after treatment in 1-6% of patients. They are treated with an additional course of therapy to which the organism is susceptible. Chronic carriage. Chronic carriage with excretion of organism in the stool occurs in 1-6% of patients. Rates are higher in patients with biliary tract abnormalities. Carriers do not develop recurrent diseases but pose a risk to others, particularly if they are food handlers. Eradication therapy with fluorochemicals from 4 weeks is indicated. And hysterectomy may be recurred. Prevention. There are 2 vaccines available for protection against Salmonella typhi. Neither is completely effective, nor do they provide protection against Salmonella paratyphi. The leaf oral vaccine TI21A has an effective of 35% and 58% at year 1 and years 2, respectively. The parenteral V polysaccharide vaccine has an efficacy of 69% and 59% at year first and year second, respectively. Immunization is recommended for travelers to high-risk areas such as Indian subcontinent. The main 2 main typhoid fever prevention stages. First is vaccination. First type of vaccine contains killed Salmonella typhi bacteria administered by a shot. Second type of vaccine contains a live but weakened strain of the Salmonella bacteria that causes typhoid fever, taken by months. So, what needs to do? Be vaccinated against typhoid while traveling to a country where typhoid is common. Need to complete your vaccination at least 1 week before travel. Typhoid vaccine lose their effectiveness after several years, so check with your doctor to see if it's it's time for booster vaccination. Second part is avoid risky food and drinks. Win it by bottled drinking water or bring it to a rolling boil for 1 minute before drinking it. Ask for drinks without ice unless the ice is made from bottled or boiled water. Avoid uh, popsicles and flavored ices. Eat food that have been thoroughly cooked and that are still hot and steaming. Avoid raw vegetables and foods that cannot be peeled like lettuce. When eat raw fruit and vegetables that can be peeled, peel yourself. Don't eat the peeling. Avoid food and beverage from street vendors. Chronic carriage cures following primary infection in approximately between 2 5% of cases in absence of antibiotic treatment and is strongly dependent on age and sex. However, the contribution of chronic carriers to typhoid transmission in endemic regions is unknown. Several safe and effective vaccines that could help reduce disease burden are licensed and available in India. 3 or 4 doses of orally administered live attenuated TY21 provide about 50-70% protection for at least 7 years and are licensed in capsule from 5 years of age or as liquid formulation from 2 years of age. The single doses injectable V polysaccharide vaccine provides similar levels of protection for at least 3 years and it is licensed from 2 years of age. A V uh, polysaccharide conjugated to Pseudomonas aeruginosa exotoxin A as a carrier protein and administered to 2 5-year-old children gave approximately 90% protective efficacy against typhoid over 4 years. More recently, 2 V polysaccharide vaccines conjugated to tetanus toxoid have been licensed in India from 3-6 months of age based on their encouraging uh, immunogenicity. The immunogenicity of conjugate typhoid vaccine in children under 2 years of age. Um, the World Health Organization recommends the programmatic use of typhoid vaccine for controlling endemic disease. Also, in the most countries vaccinated, only high-risk population is recommended. In India, routine typhoid vaccination is not implemented, and decision making has been hampered by the lack of reliable disease burden data, with very few prospective surveillance studies in the past 2 decades. The one exception where we aware in the daily, where each year approximately 3,000 children um, uh, 300,000 children aged to 5 years are vaccinated with V polysaccharide vaccine. With the recent development of conjugate vaccine that can be administered to children under 3 years old. The case for more widespread immunization is stronger, and in 2014, in Indian Academy of Pediatrics Advisory Committee on Vaccines and Immunization Practices strongly urged the government of India to include universal typhoid vaccination in its country. Thank you for attention, and I uh, would to give some short videos about typhoid fever to you. Thank you for attention.